Hello everybody and welcome to our module on shunts. In this video I'm going to talk about congenital heart defects where blood is shunted between the left and right sides of the body. So for example, you may know that on the right side of the heart blood flows from the right atrium to the right ventricle to the pulmonary arteries. It then goes through the lungs. After the lungs, blood flows through the left side of the heart, including the left atrium, the left ventricle, and then finally to the aorta. So in this video we'll talk about an atrial septal defect. That is a communication between the right atrium and the left atrium. We'll also talk about a ventricular septal defect, which is a communication between the left ventricle and the right ventricle. And finally, we'll talk about a patent ductus arteriosus, which is a communication between the pulmonary artery and the aorta. Under normal circumstances, the left-sided pressures in the body are always greater than the right-sided pressures. For example, the normal left atrial pressure is about 10 millimeters of mercury, which is more than the right atrial pressure of about 6. In the left ventricle, a normal pressure is about 120 over 10 compared to the right ventricle, where it's about 24 over 6. And finally, in the aorta, the blood pressure is what you measure when you take the blood pressure in clinic. That's about 120 over 80, and compare that to the lower pressure in the pulmonary artery of 24 over 12. What this means is that if you have a left-to-right connection, you should always get left-to-right flow. And so for this reason, in most circumstances, when you have a VSD, blood will flow from the left ventricle to the right ventricle. That's because pressures are higher on the left side of the body. Same thing in an ASD, blood usually flows from the left atrium to the right atrium, and in a PDA, blood usually flows from the aorta to the left pulmonary artery. So when children are born with one of these shunts, there will be left to right flow, as I just described. This will lead to volume overload of the right heart. However, in many cases, the right heart can tolerate the extra volume. This means that blood will flow to the lungs normally, the blood flow to the lungs will be unimpaired, and there will be no cyanosis. And that makes these defects very different from other defects I talk about in the video on cyanotic heart disease. Children with those conditions like tetralogy of Fallot have cyanosis at birth. You generally do not see this in the shunts I'm going to talk about in this video. Now, if you leave one of these shunts untreated for many years, eventually the pulmonary vessels will become stiff and thick and the right ventricle will hypertrophy. This will lead to an increase in the right-sided heart pressures, and eventually the pressures can get so high that the shunt reverses and now conducts blood from the right side of the heart to the left. In this situation, which takes many years to develop, cyanosis will occur. This is called Eisenmenger syndrome, and we'll talk about this at the end of this video. So because it takes many years for one of these shunts to lead to cyanosis, it is often said that these shunts cause blue kids, not blue babies, meaning that they are not cyanotic at birth, they are cyanotic many years later if the shunt goes untreated. So we'll start by talking about a VSD, which is a ventricular septal defect. And the reason I talk about this first is because this is the most common congenital heart anomaly. It's a communication between the left ventricle and the right ventricle, as depicted in this cartoon on the screen here. And it can lead to a harsh holosystolic murmur that is best heard in the tricuspid area, which is the left lower sternal border. There are many ways to characterize ventricular septal defects. They can be characterized by size, by their location in the ventricular septum. They can be characterized by whether they occur as isolated defects or associated with other defects, and in many, many other ways that you can read in your textbooks. One of the ways to classify them is by size. So small VSDs are a very tiny hole, and this restricts flow across the defect. So for that reason, these types of VSDs are called restrictive. Now, because the hole is very small, there's lots of turbulence, and therefore these types of VSDs tend to create a very loud murmur. However, the amount of shunting is small, meaning that there's a very small volume of blood that flows across the defect. So the irony here is that you can hear a very loud murmur from a VSD, and that can actually be a benign situation. In contrast, large VSDs represent a large hole in the ventricular septum. These are often called non-restrictive VSDs. These allow a significant amount of shunting, and therefore they are often closed surgically to prevent volume overload and right heart failure. These murmurs, in contrast to small holes, often don't cause a very loud murmur. Now let's talk about an atrial septal defect, or an ASD. This is a hole in the wall between the left and right atria, and it allows communication between those two chambers. And the major consequence of this hole is that it's going to add blood volume to the right side of the heart, including the right atrium and the right ventricle. Remember what I told you before, pressure in the left atrium should be higher than pressure in the right atrium. Therefore, when there's a hole in the wall, blood will flow from the left side of the heart to the right side of the heart. Because the right side of the heart will have to pump slightly more blood than the left side of the heart in this situation, the closure of the pulmonic valve will be delayed relative to the aortic valve. This creates the classic oscillatory finding in ASD, that is a wide fixed splitting of S2. The second heart sound is made up from the closure of the aortic and pulmonic valves, and because the closing of the pulmonic valve is delayed in the setting of an ASD, there will be a fixed split of the second heart sound. In addition, because of that extra blood flow on the right side of the heart, there's more blood flow across the pulmonic and tricuspid valves. This often creates a systolic ejection murmur in the pulmonic listening area. It also can rarely create a mid-diastolic murmur from increased blood flow across the tricuspid valve. Therefore, the classic oscillatory findings in the setting of an ASD are a wide fixed split of the second heart sound and a systolic ejection murmur, and sometimes a mid-diastolic murmur. Another consequence of an ASD is that oxygenated blood will travel from the left atrium to the right atrium. This will raise the oxygen saturation in the right atrium, and then that blood in the right atrium will go to the RV and raise the oxygen saturation in the RV, and then that blood goes to the pulmonary artery and raises the oxygen saturation in the pulmonary artery. You can detect this increase in oxygen saturation by doing something called a shunt run. This is where a series of blood samples is taken from different vessels and chambers of the heart. So for example, in a shunt run, you can sample the blood and measure the oxygen saturation in the SVC, IVC, right atrium, right ventricle, and pulmonary artery. In the case of an ASD, what you will see is a step up when you take a blood sample in the right atrium. Notice that in the vena cava, the oxygen saturation is about 65%, but it increases to 75% in the right atrium. That should never happen. You should never see the oxygen saturation go up as you move through the veins and the chambers of the heart. The reason this is happening is because oxygenated blood from the left atrium is crossing to the right atrium. That raises the oxygen saturation in the right atrium, and then it also raises it in the right ventricle and the pulmonary artery. And now I've cleared away my ink just to show you that you can also see a step up in the case of a VSD. In that situation, the right atrial oxygen saturation would also be 65 because there's no ASD, but when you get to the right ventricle, you now would see higher oxygen saturation because there is a defect and blood is crossing from the left ventricle to the right ventricle. You can also see a step up in the pulmonary artery in the case of a PDA. In this situation, blood from the aorta is crossing over into the pulmonary artery and raising just the oxygen saturation there and not in any of the chambers or vessels that come before it. There are a number of subtypes of ASDs. The most common subtype is called the secundum type. This is a defect in the wall between the left and right atria at the site of the foramen ovale and the ostium secundum. It's caused by either poor growth of the secundum septum or excessive absorption of the primum septum. I'll explain what I mean by this in a minute. These defects are located in the middle of the wall. In other words, they are mid-septum, and they often occur as isolated defects, meaning they do not generally occur in conjunction with other forms of congenital heart disease. Shown on the left side of the screen here is my own cartoon of the foramen ovale. I discussed this structure in detail in the video on cardiac embryology. But by way of review, the foramen ovale is formed by two structures. One, which is shown in red here, is the septum secundum. The other, which is shown in blue here, is the septum primum. And the way these two structures function in utero is that the septum primum acts like a valve, and when pressure is high in the right atrium, it can push the septum primum to the side and allow blood to flow through in the direction indicated by my arrow. And this space here in the septum primum is called the foramen secundum or the ostium secundum, and that's how secundum atrial septal defects get their name. The way that a secundum atrial septal defect can form is either from the septum secundum being too short, as shown in the middle of the screen here. If this red structure is too short, it will leave this opening after the baby has been born, and that's a secundum atrial septal defect. The other way it can form is if the septum primum has excessive reabsorption. The septum primum is reabsorbed to create this space, and if there is excessive reabsorption, it can leave a pathway here for blood to travel from the right atrium to the left atrium, and that is another way that a secundum ASD can form. And this is an echocardiogram image of a secundum atrial septal defect. This is the right atrium here. This is the left atrium here. You can see this large hole in the middle of the interatrial septum. That is what a secundum atrial septal defect looks like. Another type of ASD that you should be familiar with is the primum type. This is a hole or defect in the wall that is found at the site of the embryologic ostium primum. This type of ASD occurs when the primum septum fails to fuse with the endocardial cushions. If you look down at the bottom of the screen here, I've shown another cartoon from the video on cardiac embryology. And in that video, I discuss how the septum primum, shown in blue here, grows down towards the ventricle and fuses with the endocardial cushions indicated by this green square. If the septum primum does not grow down and fuse with the endocardial cushions, that will leave a pathway for blood from the right to left atrium, and that is a primum type of ASD. It will be found lower down in the atrial septum close to the ventricles and AV valves. So I've summarized this point here. These type of defects are located near the AV valves. In contrast to secundum ASDs, this type of ASD often occurs together with other congenital heart defects, and in particular, this is often seen as one component of so-called endocardial cushion defects. These are a collection of cardiac defects that are often seen in children born with Down syndrome. And here's an echocardiogram image of a primum ASD. This is the right ventricle here and the left ventricle here. This is the right atrium here and the left atrium here. There's a hole between the right and left atria that are located low in the interatrial septum, close to the ventricles and AV valves. Now let's talk about a patent ductus arteriosus. Recall that the ductus arteriosus shunts blood in utero from the left pulmonary artery to the aorta. It should close after birth. Functional closure occurs within about 24 hours after birth. This is caused by constriction of smooth muscle. Anatomic closure of the vessel occurs over the next few days or weeks. Basically, the vessel is obliterated and becomes a ligament called the ligamentum arteriosum. And the patency of the ductus arteriosus is maintained in utero by high levels of prostaglandin E2. The major source is the placenta. So after birth, when the placenta is lost, prostaglandin levels fall, and that contributes to closure of the ductus arteriosus. Rarely, the ductus arteriosus can remain patent after birth. This occurs in about 3 to 8 children per 10,000 births. And one high-yield thing to know about a PDA is that it is associated with the congenital rubella syndrome. Rubella is one of the torches infections that are dangerous during pregnancy. So if a mother is not vaccinated and she develops rubella infection while pregnant, she will develop rash, fever, and lymphadenopathy. Her baby, however, can develop the congenital rubella syndrome, which includes deafness, cataracts, and cardiac disease. And among the cardiac disease seen in babies born with the congenital rubella syndrome, PDAs are very common. A PDA causes a continuous murmur that is classically described as machine-like, and the word continuous is very important. Most murmurs that are caused by defects within the heart are either systolic or diastolic. A PDA is different because the defect is outside of the heart between the PA and the aorta. It causes a continuous murmur that is heard in both systole and diastole. In addition, a PDA is one of the classic causes of a widened pulse pressure. There is loss of volume in the arterial tree through the PDA. This leads to a low diastolic pressure and increased pulse pressure. To understand this, recall that your blood pressure goes up in systole as your left ventricle contracts. It then falls in diastole and normally begins to go up again at a relatively modest level of, say, about 80 millimeters of mercury. When there's a PDA, however, blood flows more rapidly out of the arterial tree. Therefore, the blood pressure can drop even lower in diastole down to, say, 40 or 30 millimeters of mercury. This creates a much wider pulse pressure, the difference between systolic and diastolic pressure. This is caused by any defect that allows blood to leak out of the arterial tree. And then finally, if left untreated, a PDA can eventually cause differential cyanosis. This is where a patient presents with cyanosis in the lower extremities and findings like blue toes, but no cyanosis in the upper extremities. For example, there may be normal fingers. This only happens when the shunt reverses and becomes right to left, and for this to occur, the PDA has to go untreated for many years. Alprostadil is a medication that can be used to maintain patency of the ductus arteriosus. Alprostadil is prostaglandin E1, and it acts just like prostaglandin E2, and it keeps the ductus arteriosus patent. The key effect of doing this is that more blood is delivered to the lungs because blood will flow, as we described before, from the aorta to the pulmonary artery. So this is useful in certain forms of congenital heart disease when there is poor blood flow from the RV to the PA, for example, in tetralogy of flow or pulmonary atresia. In both of these situations, babies can be cyanotic because not enough blood is going to the lungs, so alprostadil can be used to drive blood from the aorta to the pulmonary artery and improve oxygenation of blood. In contrast, indomethacin is a non-steroidal anti-inflammatory drug. It inhibits cyclooxygenase. This will decrease prostaglandin formation generally in the body, and this can be given to babies with a PDA, and in some situations it will close the PDA by knocking down the prostaglandin production. Let me mention a term that is often used when discussing shunts, and that is the QP-QS. So QP is the pulmonary blood flow, and QS is the systemic blood flow. And the QP-QS should be 1-to-1. In other words, the amount of blood flowing through Your pulmonary system, for example, 5 liters per minute, should be the same as the amount of blood flowing through your systemic system. However, in shunts, the QPQS may be greater than 1. So if blood is being shunted from the left side of the body to the right, then the QPQS may become 1.5 to 1, or 2 to 1, or 3 to 1. This is an important concept when discussing shunts. For example, once many shunts get to about 2 to 1, often closure is recommended to prevent flooding the right ventricle with too much volume and causing right ventricular failure. Eisenmenger syndrome is the clinical syndrome that occurs when large ASDs, VSDs, or PDAs are left uncorrected. This is largely not seen in the modern era. It's mostly historical. It used to occur years ago before there were surgeries to correct these defects. The reason Eisenmenger syndrome occurs is because the right heart is chronically overloaded due to shunting from the left side of the body. This leads to right ventricular hypertrophy and pulmonary hypertension. Eventually, the pressures on the right side of the heart get so high that the shunt reverses and becomes right to left. Now you have blood flow that is bypassing the lungs. This leads to cyanosis. It classically causes clubbing of the fingers. This is a picture of clubbing of the fingers seen in a person with uncorrected congenital heart disease. And then another classic finding in Eisenmenger syndrome is polycythemia. These patients have a very high hematocrit because they have a chronically low oxygen tension. This stimulates EPO release and increases the hematocrit. The fetal alcohol syndrome is caused by extensive prenatal exposure to alcohol. Alcohol is a teratogen, so if the mother drinks too much alcohol while pregnant, her baby can develop the fetal alcohol syndrome. This is a constellation of findings which includes characteristic facial features. This is a baby with the fetal alcohol syndrome shown on the screen here. In addition, these babies have impaired neurologic function, but the reason I'm talking about it now is because one component of the fetal alcohol syndrome is the presence of numerous congenital heart defects. Among the commonly seen defects are atrial septal defects, ventricular septal defects, and also tetralogy of Fallot. I'll finish this video with this slide and briefly discuss a PFO, which is a patent foramen ovale. I mentioned earlier in this video how the foramen ovale shunts blood in utero from the right atrium to the left atrium. In about 25% of adults, it fails to close after birth, and this leaves the adult with a foramen ovale. Now, the amount of shunting that occurs through a PFO is very small, so this usually doesn't cause any type of heart failure or right heart failure or Eisenmenger syndrome or anything like that. The one potential clinical consequence of a PFO is that it can lead to stroke in patients who have a blood clot in the venous system. For example, if patients develop a deep vein thrombosis or a pulmonary embolism, they can have a piece of that clot cross the PFO, and this can cause a stroke. Shown at the bottom of the screen is an example of a PFO on an echocardiogram. This is the right atrium here, this is the left atrium here, and you can see this flap of tissue with a black space in between that allows blood to pass. That is a PFO. And that concludes our video on shunts.